A 76-year-old woman named Eleanor Thompson walked into her doctor's office for what she thought would be a quick annual checkup. She was vibrant for her age, still tending her garden every morning, volunteering at the local library 3 afternoons a week, and even taking ballroom dancing classes with her husband of 52 years. No major complaints, just the usual aches from a lifetime of activity. Her blood pressure was a tad high, her cholesterol levels weren't perfect, and she mentioned occasional heartburn after spicy meals. Nothing alarming. But by the end of that visit, her doctor had scribbled out prescriptions for 5 new medications: a statin for cholesterol, a proton pump inhibitor for the heartburn, a blood pressure pill, an anti-anxiety med to help with stress, and a low-dose aspirin for heart protection. Eleanor left with a bag full of pills, feeling reassured at first. After all, her doctor knew best. Fast forward 6 months, Eleanor's life had unraveled. The statin caused muscle cramps so severe she could barely get out of bed some days. The blood pressure med made her dizzy, leading to a nasty fall in her kitchen that bruised her hip and scared her family. The anti-anxiety pill fogged her mind, turning her sharp wit into confusion during conversations. And the proton pump inhibitor? It seemed harmless until she developed a stubborn infection that wouldn't clear up, landing her in the ER. Worst of all, the interactions between these drugs amplified everything: nausea, fatigue, even tremors in her hands that made holding a book impossible. Her dancing days? Over. Gardening? A distant memory. She spent her time shuffling between doctor appointments, adjusting doses, and dealing with side effects that felt worse than any original issue. This isn't just Eleanor's story. It happens to millions of seniors across America every year. Polypharmacy, the fancy term for taking 5 or more medications, afflicts about 40% of adults over 65 in the US, according to the Centers for Disease Control and Prevention. And it's not always necessary. Often, it's downright dangerous. Medications that help younger folks can wreak havoc on aging bodies with slower metabolisms, weaker kidneys, and livers that can't process drugs as efficiently. Side effects pile up, interactions turn lethal, and quality of life plummets, all while the supposed benefits fade into irrelevance for someone with a limited lifespan. I'm Dr. Michael Rivera, a geriatric pharmacist with over 25 years of experience helping seniors in community clinics and nursing homes across California and Texas. I've seen the toll of overprescribing firsthand: families torn apart by unnecessary suffering, hospital bills skyrocketing, and vibrant lives reduced to shadows. The U.S. healthcare system rewards volume. More prescriptions mean more reimbursements, more follow-ups, more procedures. But for seniors over 70, more isn't better. It's often harmful. A groundbreaking study in the Journal of the American Geriatric Society revealed that deprescribing, safely stopping unnecessary meds, improved quality of life for 70% of participants without shortening their lives. In fact, it extended healthy years for many. Today, I'm going to walk you through 5 commonly overprescribed medications for people over 70 that you have every right to question, and in many cases, refuse or taper off under medical supervision. This isn't about ditching all your pills or ignoring real health issues. It's about informed choices that prioritize living well over living medicated. If you're on multiple meds or know someone who is, this could change everything. And if you find this valuable, hit that like button and subscribe for more honest talks on senior health. Let's dive in. The first medication to question is statins for cholesterol management, especially if you don't have a history of heart attack or stroke. Statins like atorvastatin, Lipitor, or simvastatin are blockbuster drugs prescribed to over 35 million Americans annually. They lower LDL cholesterol, which can prevent heart disease in middle-aged adults. But after 70, the story changes. Your body naturally shifts. Cholesterol levels often stabilize or even drop as you age. More importantly, the benefits of starting or continuing statins diminish while risks skyrocket. Let me tell you more about Eleanor. At her checkup, her total cholesterol was 210, mildly elevated, no big red flags. Her doctor, following standard guidelines, started her on 20 milligrams of atorvastatin. "It's preventative," he said. "Better safe than sorry." But for Eleanor, it wasn't safe. Within weeks, she developed myalgia, muscle pain, and weakness that made walking painful. She stopped dancing, gained weight from inactivity, and her mood dipped. A study in The Lancet followed over 10,000 seniors on statins and found no significant reduction in heart events for those without prior cardiovascular disease. Zero net benefit. Yet side effects hit hard. Muscle issues in up to 15% of users over 70, increased diabetes risk by 9%, and even cognitive impairment in some. Why does this happen? Aging muscles are more sensitive to statins, which block an enzyme needed for muscle repair. Kidneys and livers process the drugs slower, leading to buildup. And the prevention angle? Heart disease complications take years to manifest. If your life expectancy is under 10 years, common at 75 plus due to other factors, the statin won't prevent anything in time. Instead, it guarantees harm now. Official guidelines from the American College of Cardiology now advise against routine statin use in low-risk seniors over 75. They recommend shared decision-making, weighing your personal risks. But many doctors skip that talk. They see elevated cholesterol on a lab slip and reflexively prescribe. Eleanor eventually switched doctors and tapered off the statin. Her muscle pain vanished within a month. She's back in the garden, cholesterol at 215, still mild, and no heart issues in sight. Questions to ask your doctor. What's my actual risk of a heart event without this med, based on my age and health? What side effects are common at my age? If I stop, how will we monitor? If they brush it off with protocol, that's a sign to seek a second opinion. The second medication to scrutinize is proton pump inhibitors, or PPIs, for acid reflux or heartburn, like omeprazole, Prilosec, or esomeprazole, Nexium. These are among the most prescribed drugs in America, with over 15 million seniors on them long-term. They work by reducing stomach acid, easing symptoms quickly. Great for short-term use after an ulcer or severe GERD, but after 70, chronic use is a ticking bomb. Take Harold Jenkins, a 78-year-old retired mechanic from Ohio. He started on omeprazole for occasional indigestion after big meals. "Just take it daily," his doc said. "It'll prevent problems." 2 years later, Harold fractured his hip slipping on ice. Turns out long-term PPIs weaken bones by impairing calcium absorption, increasing fracture risk by 25 to 40% per a meta-analysis in JAMA. Then came the infections, a bout of C. diff diarrhea that hospitalized him as PPIs disrupt gut bacteria, raising infection odds by 65%. And kidney issues crept in. Chronic use links to a 20 to 50% higher risk of kidney disease. Why the harm? Seniors produce less stomach acid naturally, so suppressing it further disrupts digestion, nutrient uptake like B12, leading to anemia and neuropathy, and the gut microbiome. Infections thrive without acid's protective barrier. And the prevention for mild reflux? Often unnecessary. Lifestyle tweaks like smaller meals, elevating the bedhead, or antacids as needed suffice without risks. The American Gastroenterological Association urges deprescribing PPIs after 8 weeks for most cases, yet 60% of seniors stay on them indefinitely. Harold's new geriatrician helped him wean off over 2 months, using H2 blockers temporarily. No more heartburn flares, bones strengthening with supplements, and energy back. He wishes he'd questioned sooner. Key questions. How long do I really need this? What are the long-term risks for my bones, kidneys, and infections? Are there safer alternatives like diet changes? Moving to the third, benzodiazepines for anxiety or sleep, such as lorazepam, Ativan, or alprazolam, Xanax. These sedatives are prescribed to 1 in 10 seniors, often for mild anxiety or insomnia. They calm the brain quickly, but in older adults, they're a recipe for disaster. Consider Maria Gonzalez, 74, from Florida. After her sister's death, she felt anxious and couldn't sleep. Her doctor gave her Xanax as needed. Soon, it was daily. Within months, Maria fell 3 times. Benzos increase fall risk by 50 to 60% in seniors, per the Beers criteria, a list of potentially inappropriate meds for elders. One fall broke her wrist, another caused a concussion. She became forgetful, mixing up appointments, and dependent. Stopping cold turkey risked seizures. Aging brains are more sensitive to benzos. They linger longer, causing daytime drowsiness, confusion, and coordination loss. Long-term use links to dementia risk up by 50%, depression, and even higher mortality. Benefits? Short-lived. Tolerance builds fast, worsening the original issue. The American Psychiatric Association recommends against benzos in seniors, favoring therapy, melatonin, or CBT for insomnia. Maria switched to non-drug approaches, mindfulness apps, evening walks, sleep improved, no falls in a year. Questions: is this the safest option for my age? What non-drug alternatives exist? How will we plan to taper if needed? The fourth medication is blood pressure drugs with overly aggressive targets, like aiming for under 120/80 in frail seniors. Meds such as lisinopril or amlodipine are vital for hypertension, but pushing too low is harmful. Robert Klein, 77, from New York, had blood pressure of 150/90, high but stable. His doc added meds to hit 120 per guidelines. Soon, Robert was dizzy, lightheaded, falling in the shower. Low BP caused orthostatic hypotension, common in 30% of treated seniors over 70. A sprint trial follow-up showed aggressive control increased falls and kidney strain without longevity gains in elders. Guidelines now suggest 140 to 150/90 for many over 75, prioritizing symptoms over numbers. Robert's adjusted target to 140 eased symptoms, no strokes, better life. Questions: what's a safe BP goal for me? Risks of low BP. Monitor how. The fifth and final is bisphosphonates for osteoporosis, like alendronate, Fosamax. Useful for high fracture risk cases, but long-term use past 5 years is questionable. Louise Patel, 72, from Illinois, started after a bone scan showed osteopenia. 5 years in, she developed jaw pain, osteonecrosis, a rare but serious side effect in 1 to 2% long-term users. Atypical femur fractures also rise with prolonged use. Studies show benefits plateau after 3 to 5 years. Drug holidays are recommended. Louise stopped after evaluation. Bones stable with exercise, calcium. Questions: how long should I take this? Side effect risks. Alternatives like weight-bearing exercise? We've covered 5 meds: statins, PPIs, benzos, aggressive BP control, and bisphosphonates. But there's more to consider: how these interact, the cascade of adding meds to treat side effects. Let's circle back to Eleanor's full journey. After her fall, she ended up in the hospital for 3 days. Doctors ran tests, added more meds for pain and nausea. It was a vicious cycle. Her daughter, a nurse, intervened, researching polypharmacy. They found a geriatric specialist who reviewed her regimen. Over 6 months, they deprescribed 4 of the 5 new meds, monitoring closely. Blood tests, follow-ups, it wasn't abrupt. Eleanor's energy returned, she lost the extra weight, danced again. Her story highlights the human cost. Statistics paint a grim picture. The Lown Institute estimates over-medication causes 150,000 premature deaths yearly in U.S. seniors, plus millions in hospitalizations. Costs: billions in Medicare dollars wasted on unnecessary pills. Why does this persist? Pharma marketing targets doctors with perks. Guidelines lag behind elder-specific data, and time-crunched visits favor quick scripts over discussions. A survey in Annals of Internal Medicine found 80% of primary care docs admit overprescribing due to patient expectations or fear of lawsuits. But change is possible. Programs like the Choosing Wisely campaign, backed by the American Board of Internal Medicine, urge questioning routine practices. For meds, they emphasize deprescribing protocols. Now, delving deeper into statins, beyond muscle pain, there's rhabdomyolysis, a rare but life-threatening breakdown of muscle tissue leading to kidney failure. Risk jumps 5-fold over 70. And cognitive effects. Some report statin brain fog, though studies are mixed. A Cochrane review concluded no cardiovascular benefit for primary prevention in low-risk elders. For PPIs, nutrient deficiencies extend to magnesium, causing arrhythmias, and iron, anemia. Gut changes increase pneumonia risk by 30%. Alternatives? Elevate bed, avoid triggers, use alginate for reflux barriers. Benzos withdrawal is hellish. Insomnia rebound, anxiety spikes. Taper slowly over weeks. CBTI apps like Sleepio are evidence-based for sleep. BP management. The Accord trial showed intensive control harmed diabetics over 70, increasing adverse events. Personalized calculators like the Framingham Risk Score help tailor goals. Bisphosphonates, after 5 years, reassess with DEXA scans. Denosumab is an alternative injection, but has its own rebound fracture risk upon stopping. Interactions amplify dangers. Statins plus PPIs can increase muscle toxicity. Benzos plus BP meds heighten falls. Use tools like the Beers list to flag risks. Empower yourself. Keep a med list, including OTCs. Ask about each pill's purpose, duration. Consider pharmacist reviews. Many pharmacies offer free med checks. Eleanor's turnaround inspired her to join a senior advocacy group, sharing her story at community centers. "I felt like a guinea pig," she says. "Now, I ask questions." As we approach the midpoint of this discussion, remember, your health is your right. Questioning isn't defiance, it's partnership. In the next part, we'll explore real-world strategies for deprescribing, more patient stories, and how to navigate doctor conversations effectively. As we continue this conversation, let's talk about how to actually make deprescribing happen in real life. Because knowing the risks is one thing, but getting your doctor on board is another. Most seniors don't realize they have the power to push back. Doctors are busy, protocols are ingrained, and many genuinely believe more medication equals better care. But the evidence shows otherwise for those of us over 70. The key is preparation, persistence, and the right questions. First, let's look at another real patient story that illustrates the interaction dangers I mentioned earlier. Meet George Whitaker, an 81-year-old veteran from Pennsylvania. George was already on a statin and a blood pressure medication when he started having trouble sleeping after his wife passed away. His primary care doctor, someone he'd seen for 15 years, prescribed a low-dose benzodiazepine just to get through this tough time. A few months later, George mentioned occasional heartburn at a follow-up, so the doctor added a PPI. Then, because his cholesterol crept up slightly despite the statin, the dose was increased. 5 medications in total, all seemingly reasonable on their own, but the combination was devastating. The benzo made him groggy in the mornings. The higher statin dose caused leg cramps. The blood pressure pill, combined with the benzo's sedative effect, dropped his pressure too low when he stood up quickly. One morning, he blacked out in the bathroom, hit his head on the sink, and ended up with a subdural hematoma, a slow brain bleed that required emergency surgery. He spent 2 weeks in the ICU and another month in rehab. At 81, recovery was brutal. He lost 20 pounds, couldn't walk without a walker for 6 months, and his sharp mind dulled from the trauma and lingering meds. George's daughter flew in from Colorado and demanded a full medication review. A hospital geriatrician identified the cascade. The benzo amplified the blood pressure med's orthostatic effects. The statin contributed to muscle weakness, increasing fall risk, and the PPI may have impaired magnesium absorption, worsening cramps. They slowly tapered the benzo first, then reduced the statin dose, switched the PPI to as-needed antacids, and adjusted the BP target upward. George regained strength, moved back home, and today, at 84, he's driving again, playing cards with friends, and says he feels better than he has in years. Stories like George's aren't rare. A 2023 study in the Journal of the American Medical Association estimated that adverse drug events cause over 280,000 hospital admissions annually among Medicare beneficiaries, with polypharmacy as the leading culprit. Many of these are preventable. The problem is that medications are often added one at a time by different specialists without anyone looking at the big picture. Your cardiologist adjusts the statin, your gastroenterologist starts the PPI, your primary adds the benzo. Nobody connects the dots. This is where a comprehensive medication review comes in. Every senior over 70 should request one annually, ideally with a geriatrician or a clinical pharmacist trained in de-prescribing. Medicare Part D plans are required to offer medication therapy management services for free if you take multiple drugs or have certain conditions. Yet only about 10 to 15% of eligible seniors use it, according to CMS data. It's a missed opportunity. During an MTM review, the pharmacist looks at every pill, prescription, over-the-counter, supplements, and asks, is this still necessary? Is the dose appropriate for my age? Are there dangerous interactions? Could a non-drug approach work better? They then send recommendations to your doctor. In one large trial published in Annals of Internal Medicine, MTM reduced potentially inappropriate medications by 35% and cut emergency visits by 20%.
If you can't access a formal review, do it yourself with tools like the American Geriatric Society's Beers Criteria list, available free online. Print it, highlight anything you're taking, and bring it to your next appointment. Or use apps like MedSafe or the deprescribing.org resources, which guide you through risk assessments. Now, let's talk strategy for the doctor conversation, because this is where most people get stuck. Doctors aren't villains. They're overworked, facing 15-minute visit slots, and trained to do something. Saying no to a prescription feels risky to them too, but you can shift the dynamic. Start with appreciation. Doctor, I trust your judgment, and that's why I want to have this discussion. Then share your goals. My priority right now is staying independent, gardening, driving, spending time with grandkids. I'm worried these side effects are getting in the way. Frame it around quality of life, not just numbers on a chart. Next, ask the 3 magic questions I always recommend. Given my age and overall health, what's my realistic life expectancy? This forces the doctor to think beyond guidelines designed for 50-year-olds. Tools like the e-prognosis calculator from UCSF can estimate it based on function, comorbidities, and labs. If it's under 10 years, many preventative meds lose their value. If I stop or reduce this medication, what exactly are we watching for and how will we monitor? This addresses fear of missing something. Good doctors will outline a plan, perhaps more frequent checks of certain labs or symptoms. And what does the evidence show specifically for someone my age? Not general guidelines, but age-stratified data. For example, the statin trials often excluded people over 75 or showed no benefit in that subgroup. Write these down. Bring a family member or friend for support. If the doctor dismisses your concerns with "it's standard of care" or "better safe than sorry" without addressing your questions, that's a red flag. You're allowed to seek a second opinion. Geriatricians are specially trained in these nuances. Find one through the American Geriatric Society directory. Let's circle back to Eleanor one more time, because her journey didn't end with just stopping meds. After de-prescribing, she still had mild cholesterol elevation and occasional heartburn. Her new doctor focused on root causes: diet, movement, stress. They referred her to a registered dietitian covered by Medicare for certain conditions who helped tweak her meals: more fiber, less processed food, smaller evening portions. Her heartburn nearly vanished. She joined a senior strength training class twice a week, which not only improved muscle tone, but naturally lowered her blood pressure and cholesterol. Lifestyle changes that would have been impossible while battling side effects.
This is the bigger message. Deprescribing opens the door to real health. When you're not foggy, weak, or dizzy from pills, you can exercise, eat better, sleep naturally, and enjoy life. It's not about doing nothing. It's about doing what actually works for your stage of life. I want to share one more patient story before we wrap up the medication-specific discussion. This one involves all 5 categories overlapping, which is common. Betty Morrison, 79, from Arizona. Betty had mild osteoporosis diagnosed at 70, so she started alendronate. At 72, her cholesterol was borderline, statin added. At 74, blood pressure crept up, lisinopril started with a low target. At 76, heartburn from NSAIDs for arthritis, PPI prescribed. At 77, trouble sleeping after her husband's dementia diagnosis, lorazepam for anxiety. By 79, Betty was a shell of herself. Jaw pain from the bisphosphonate, muscle aches from the statin, dizziness from the BP med, recurrent infections from the PPI, and falls from the benzo. She moved into assisted living after a hip fracture, convinced she was just getting old. Her son, researching online, found a deprescribing clinic at a nearby university hospital. Over 9 months, they tapered everything except a low-dose BP med with a relaxed target. The bisphosphonate was stopped after 9 years, well past the recommended holiday point. The PPI switched to occasional use. The benzo tapered slowly with CBT for sleep. The statin discontinued after confirming low cardiovascular risk. Betty moved back to independent living at 80. She's now 82, line dancing 3 times a week, volunteering at her church, and says, "I got my life back." Betty's case shows the cumulative toll. Each drug alone might have seemed justifiable. Together, they stole years of vitality. As we move toward the end of this discussion, let's summarize the 5 medications again with key takeaways. Statins in low-risk seniors over 75. Often no survival benefit, high muscle and cognitive risk. Ask about your personal ASCVD risk score. Long-term PPIs. Beyond 8 to 12 weeks, risks, fractures, infections, kidney disease, usually outweigh benefits from mild reflux. Try lifestyle first. Benzodiazepines, among the most dangerous for seniors. Fall risk, dependence, and dementia link. Non-drug options exist and work better long-term. Overly aggressive blood pressure targets. Below 130/80 can cause more harm than good in frail elders. Guidelines now support higher goals. Bisphosphonates beyond 5 years. Benefits plateau. Risks like jaw necrosis and atypical fractures rise. Reassess with bone markers and DEXA. Remember, none of this is medical advice for your specific situation. Always work with a healthcare professional. But you deserve to be an informed partner in that process. Before I close, I want to touch on one final point, the emotional side. Many seniors feel guilty questioning their doctor. They're the expert, we think, or we worry about seeming difficult. But true experts welcome questions. The best doctors say, "I'm glad you asked," and if yours doesn't, it's okay to find one who does. Also, don't go it alone. Involve family. Join online communities like the Deprescribing Network or senior health forums where people share experiences. Knowledge is power, and shared knowledge multiplies it. Eleanor, George, Harold, Maria, Robert, Louise, Betty, they all regained quality of life by questioning the default path. You can too. If this conversation has helped you or someone you love, please hit like, share it with a friend on multiple meds, and subscribe for more straightforward talks about senior health. We need to spread this message because mainstream medicine isn't always serving our elders well. Thank you for spending this time with me. Live well, question wisely, and cherish the years you have.